Well, thank you for the introduction. A question, just to start, is whether or not androgen excess in the aged woman should be investigated because they can produce side effects or clinical diseases is totally unknown based on the literature we have. So I will not speak about mechanistic aspect of the relationship between, for example, metabolic issues or cardiovascular issues and androgen, particularly in women in postmenopause, but I will present you the data about two big areas. The area of the most common disorders associated with androgen excess, that is a PCOS, polycystic ovary syndrome, and the second one is a classic congenital adrenal hyperplasia. So I will start with PCOS. This is the target. The target is the metabolic issues. And because of the metabolic issues that can be affected by age, particularly after the menopause, we can suggest that there is some development of some diseases, for example, diabetes or cardiovascular diseases, or even increase in mortality because of androgen excess. This is a forgotten area. It's important to have in mind that, by definition, it's difficult to define whether or not a postmenopausal woman has PCOS because we have not this important criteria, that is a reproductive phenotype. By contrast, we have the hyperandrogenic phenotype. Although androgen levels tend to decrease, but are still higher than expected. Conversely, we have the metabolic phenotype. So the main problem of the aged woman with PCOS, for example, after menopause, is the metabolic aspect and the susceptibility to develop diseases such as diabetes or cardiovascular diseases. Doesn't work? They have to do. My God. It's blocked. Something happened. Okay. Is it blocked? Okay. So, one problem is, do women after menopause have androgens? The reply is yes. This is an old study showing that young women and postmenopausal women, they have androgens. Not only estrogen reduced anyway, but they have androgens. So having androgens after menopause is physiology, is not pathology. And with respect to PCOS, we can see that androgen excess persists after menopause, even if androgen concentration is lower and during the previous years before menopause by itself. It continued to be blocked. What they have to do? It's a problem.
We will find it.
Last lecture, big problem.
Let's see. Just a minute, just a minute. Okay. Okay. You will put only this two. Okay.
We have some information from animal study focusing on the effect of androgens and age on metabolic issues. And in this model, you can see that hyperandrogenemia may persist with age in these animals and is associated with an increased insulin, worsened glucose metabolism, particularly in non-fasting states. So, for example, after an OGTT. So we have specific information from animal studies that androgen can affect metabolic issues. We have no many research in this area, even in animal studies. So it's important to keep in mind that this can be used as a reference for human studies. What happens, for example, between the association between androgens in men and in women and the metabolic syndrome? Look at the picture. You can see that in men on the left, with decreasing androgen, particularly testosterone concentration and sexual body globulin, there is an increase in a phenotypic expression of the metabolic syndrome. Exactly vice versa. In this case, this happens. Right? In this case, with increasing androgen concentration, we have an increase in the prevalence of the metabolic syndrome. So we have a gender or a sex difference. No doubt that this one, on this.
Yes. I think you push the other one with your hand, you put this one.
It could be. Okay, you are right. Okay, sorry, I'm joking. So no doubt that in women, metabolic issues are totally related to androgens. And what about the definition of PCOS? My personal, not only my personal point of view, is by definition, PCOS is an hyperandrogenemic disorder. All PCOS should have androgen excess. The problem is not testosterone. The problem is the pool of androgens. For example, in this paper, we found that if you add androstenedione or free testosterone to testosterone by itself, 90% women are defined as PCOS. A 10% of so-called PCOS by definition uses the two criteria, ovarian morphology and ovarian dysfunction, but no androgen excess. Are they PCOS is a question mark. In my opinion, they are not PCOS. It's a different phenotype. So we have to start with the concept that there are other studies focusing on this aspect, that hyperandrogenemia is a constitutive biomarker of PCOS. And without androgen excess, PCOS is totally different. So we can start from this point of view. Androgen excess is a principal biomarker of the disorder. And the sensitivity and specificity of the profile of androgens is very high. So it's quite simple to define androgen excess, regardless testosterone or androstenedione or free testosterone, or possibly DHT or the combination of the three or the four. So a new data coming from since 2012 or 13 is the demonstration that there is an association between the amount of androgen you have and the amount of metabolic disorders you have. Which metabolic disorder are you speaking about? Metabolic disorder has impaired glucose tolerance, insulin resistance, dyslipidemia, and so on. The so-called metabolic issue. And you can see here that if you have high androstenedione and high testosterone, you have a large proportion of women having these metabolic issues. So is another piece, the picture, defining that PCOS is an hyperandrogenemic disorder by definition. Obviously, insulin insensitivity or insulin resistance is a biomarker, is an important, but is not a disease per se. It's a condition predisposing to diseases. And the principal diseases particularly diabetes type 2, but even possibly cardiovascular diseases, and possibly infertility, but it is another problem. So look at what happened, for example, for diabetes in men and in women. There is an increase in diabetes rate, my God, according to BMI. And the maximum of diabetes prevalence is related to a very high BMI, more than 35. But the number of men reaching this are more or less 40%, 45%. Look at women, the same profile. But the main difference is, obviously there is a relation with an increase in BMI. The main difference is that the rate is not 45, the rate is 80. So after menopause, women are susceptible, much more than men, to type 2 diabetes. And these are prevalence data, are coming from different countries, old studies, but new studies confirm this one. So what about the prevalence of impaired glucose tolerance and in women with PCOS? No doubt you can see that there is a higher prevalence of impaired glucose tolerance in all these studies, regardless of the subgroup classification. So glucose intolerant states are constitutive of the history of PCOS. And what about diabetes? Diabetes is one of the first studies focusing on the prevalence of diabetes in PCOS, and most importantly on the ability to convert from impaired glucose tolerance to diabetes, or from normal glucose tolerance to impaired and then to diabetes. And the final conclusion was that the conversion rate is higher, reaching, starting from impaired glucose tolerance, reaching values of 8.7 per year %. So it's quite evident that impaired glucose tolerance or glucose intolerant states are strongly related to PCOS, and are strongly related to PCOS because of the association with obesity and the presence of androgen excess. What about a follow-up study? We follow up more or less 200 women, and we found the following, that in Italy, the prevalence of diabetes was 5 times higher than the general population in women with PCOS. And the rate of diabetes was strongly associated to not only PCOS, but the presence of obesity. You can see here that the risk ratio was very high with BMI, with increasing BMI, particularly BMI higher than 30. So the incidence of diabetes in PCOS women, if they are obese, is more or less like this. So it's very high. Other studies confirm this observation. We have very few studies on prevalence or incidence, prospective studies, more of them are retrospective, but even if more of them are retrospective, collectively we have very few studies on the very important problem. And if you look at the data, you can see that the incidence rate in UK of type 2 diabetes in PCOS was 3.7, and higher than expected with respect to the general population. And this clearly affected by the combination of PCOS with age. Therefore, with increasing age, even the studies confirmed that the association between PCOS and diabetes is very strict. Another study performed in the UK, retrospective, looking at the list of items, that is diabetes or mortality or cancer and so on, found a close association. No doubt that on the left you can see that the prevalence of type 2 diabetes was higher in PCOS than in the control population. And this was if you adjusted for BMI. And this finding confirms again that the combination of the disorder or disease, PCOS, and BMI may be responsible for the presence of diabetes. It's not the problem of BMI, it's the problem of a combination of the two. What about cardiovascular diseases? These are the old data taken from a big publication 15 years ago. As you can see, it appears that men are affected by cardiovascular diseases. Women, much less. Is it true or not? It's not true. And the main explanation is that women are underrepresented in these studies, even in epidemiological studies or interventional studies. Look at the data for coronary artery disease or heart failure, diabetes, hypercholesterolemia or hypertension, and the gray bar are women. So there is a sex disparity between women and men according to the epidemiology and management of specifically cardiovascular diseases. So I suggest it's important to look what happened in PCOS after menopause in relation to cardiovascular diseases, cardiovascular events, cardiovascular risk factor, and even mortality for cardiovascular diseases. There are very few studies, no more than 5 to 6. This is one of the studies. They evaluated a condition not defined as a risk factor, but properly speaking, as part of the progression of the disease, that is the calcification and carotid intima media. And no doubt that PCOS had a higher prevalence of calcification and carotid intima media with respect to the controls. So vessels seem to be much more affected in these women. Another study looking at the mortality rate in women with PCOS in a long-term follow-up in more or less 800 women with PCOS in UK did not find any difference between PCOS mortality and control mortality, suggesting that one thing is atherosclerosis or cardiovascular diseases. Another thing is mortality because of atherosclerosis and because of heart or brain damage. Another study in a relatively small number of postmenopausal women with a history of so-called PCOS based on irregular menses or hyperandrogenemia, that is testosterone. They found that there was a significant difference in cardiovascular death or myocardial infarction, and the p-values was highly significant. And those women particularly affected by the chance to die because of cardiovascular disease were those with the higher values of free testosterone. So these studies published different data suggesting high testosterone and PCOS status can in fact be a factor favoring mortality because of cardiovascular diseases in women. What about general mortality? Again, the same study I presented before. This large study, a retrospective study, even if adjusted for BMI, didn't find any difference in mortality rate between PCOS and controls. So the literature, the available literature, mostly retrospective, failed to give message, a clear message. The message is it true that cardiovascular disease are a potential evolution of PCOS after menopause? Based on this data, it could be true, but it's not based on the data, because probably cardiovascular diseases are more represented, but the mortality rate because of cardiovascular disease is more or less the same. This is another aspect focusing on a cumulative 10-year mortality, 28% in PCOS, a small number, and 27% in women without PCOS. And the rates were not significant. So this study in a smaller number of women against says that the mortality rate is more or less the same. Therefore, we can conclude that lifelong metabolic dysfunction in PCOS exaggerates cardiovascular risk. And there's no doubt that is true, especially after menopause. Also, surrogate markers of cardiovascular risk are higher in PCOS. But mortality and cardiovascular event followed by deaths are more or less the same or are a matter of further research. Among non-diabetic postmenopausal women, women with intact ovaries, atherosclerosis, cardiovascular diseases, and cardiovascular are associated with feature of PCOS, particularly with androgen excess. So a putative role of androgen excess versus metabolic issues particularly, and possibly even versus the cardiovascular system, it's possible. On the other hand, it's still not clearly defined whether or not PCOS is a condition anticipating the death because of cardiovascular diseases. So a brief focus on classic congenital adrenal hyperplasia. The metabolic issues are the classic form and even the non-classic form, the late onset congenital adrenal hyperplasia are well known. And generally speaking, are more or less similar to those found in the PCOS area. The problem is whether or not these women, they are not so few. It depends. We have more or less approximately 250 classic women, ex-girl, with the classic form of congenital adrenal hyperplasia, and 250 women are the big cohort. Obviously, not all centers, they have many women with this disorder, even because the transition phase fails around the world. It's quite uncommon that the transition phase from pediatricians to adults endocrinology is taken at a true time in the 18s or 20 years old. In our experience, pediatricians follow their patient even in the 40s, even in the 50s, even in the 60s. So it's incredible how it's different, the perspective of a pediatrician with respect to this disorder, with respect to an adult endocrinologist or doctor, generally speaking, focused on the maintenance of health for a long period of time. What happens in this so-called rare disease? You can, based on this data in Sweden, they are used to have national cohort. They measure a lot of things. Look at the data, you can see that in women with congenital adrenal hyperplasia, there is some higher incidence of diabetes, for example, hypertension, obesity, and any cardiovascular or metabolic diseases, and even in hypothyroidism, not in another list, for example, or heart failure, atrial fibrillation, and so on. So no doubt that women with, aged women with congenital adrenal hyperplasia, classic one, including salt wasting or not, but all with a cortisol deficiency, they have some metabolic and cardiovascular issues. So look at what happens, for example. It's very rare to find the data on this specific, written by adult endocrinologists, not by pediatrician endocrinologists, because the perspective is totally different. Look at the profile of blood pressure. No doubt that blood pressure is increased in these women, but not a list of other metabolic issues, including BMI or glucose and so on. So it's an open question whether or not this so-called rare, but not rare when you have a lot of women with this disorder, have metabolic issues affecting in time possibly the cardiovascular system through diabetes or without diabetes, and even to increase the probability to die before the time or the due time. For example, you know that these girls, they become women, are treated with corticosteroids. They are treated with anti-aldosteronemic compounds just to restore the balance. And one of the main problems in the treatment of these women during the pediatric era, and particularly after, is the amount of glucocorticoids you are giving. And not the, generally speaking, glucocorticoid, but the type of glucocorticoid you are using. So, based on the data, there is some aspect and potential probability that the true problem in these women is not the disorder per se, but is the treatment. They are overtreated for many, 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 many decades and decades. So it's a big problem because you can't go back. This is a main problem, for example, to understand that the transition phase should be performed very quickly when a woman, and obviously a man, is adult, and not to treat adolescent adult individuals, because this is the main problem. In our hands, for example, half of the women, because they are women, the average age is 34, 35, is overtreatment with glucocorticoids. And overtreatment with glucocorticoids could be responsible for increased metabolic damage and even cardiovascular diseases. This confirms that the mortality rate in these women could be higher. But again, the question is, why it's higher? It's higher because of adrenal crisis, the most common, cardiovascular diseases, even cancer, and even suicide. So when you are speaking about death in these women, you have to take into consideration that, for example, the adrenal crisis is very common in these women. So they can die because of this. It's not a problem of metabolic issues and cardiovascular. So the perspective is totally changed, totally different with respect, for example, to the principal hyperandrogenemic disorders in women, that is PCOS. So look at the data, even on bone density. Bone density seems to be affected and seems to have low body mass density and therefore an increased risk for fractures. These are the available data. No other study, important study, prospective study, or mechanistic study. But the most important information is that these adult congenital adrenal hyperplasia women, they have metabolic issues, they have cardiovascular issues. And the second most important issue is that it's probably related to the damage to the treatment, not to the disorder. And the history, therefore, in these still hyperandrogenic women in the postmenopausal era is a pathophysiology. In this case, is treatment, the main cause. In PCOS women is probably another thing. It could be that androgens, as I believe, are responsible for the onset of diabetes in these women, which represent the main metabolic disorders in women with PCOS. So just to conclude, I would like to repeat something that is the prevalence and incidence of the metabolic syndrome and type 2 diabetes, no doubt, is higher in PCOS. There are conflicting data whether an increasing age, particularly after menopause, in these women with androgen excess, they have an increased risk for cardiovascular diseases, but most importantly, for mortality. No studies on the potential preventive strategies, lifestyle, drugs, and so on, in aged PCOS women is available. This because I didn't speak about treatment, because we have not treated. Otherwise, it could be we have some treatment. You can discuss or speculate about it. And in women with congenital adrenal hyperplasia, particularly classic 4, there is some evidence that the potential high prevalence of the metabolic and cardiovascular diseases are not related to the disease per se, but are likely related to the treatment, particularly with the glucocorticoids in excess. Thank you.